we make you say Nessun Dormo.
Let's give it one more minute.
Let's go ahead and get started. Hello, everyone. Welcome. It is my privilege to introduce Michael Kolesnikov, who is defending his dissertation today. But in addition to being a PhD student, Michael is also an advanced practice provider here at OHSU in trauma surgery. We're very lucky to have him. And so the topic that Michael is going to talk to you about is near and dear to his heart, with important implications for clinical practice and for patient care, not just at OHSU, but everywhere. So with that, I also promised Michael I would introduce him in the form of a haiku, but I will not.
Thank you.
Welcome, and thank you so much for doing this.
Thank you, Dr. Mohan. All right, so the topic of my presentation is feasibility of using machine learning for clinical decision support to optimize transfusion practices in trauma care. First of all, I would like to make a couple of acknowledgements. I want to thank my dissertation advisory committee, Dr. Vishnu Mohan, who is Dr. Karen Eden, who is our chair of the committee, and Dr. Leslie Kirai, who is our trauma and transfusion expert, Dr. Stephen Bedrick, who is our machine learning expert, Dr. Chris Hexter, who is our qualitative research expert, and Dr. Nicole Westcott, who is our examiner. Also, I would like to say thank you to DMI's faculty and staff and students for their collaboration throughout the 7 years. Trauma program, Adrian and Amanda for keeping my schedule sane, Reina and Rebecca for getting me the resources I needed, and also Don and Siran for getting the special data for me, which was, I had lots of requests for the data. Also, daily weather data was provided by August Diaz, who is works for Custom Weather. And last but not least, radiology department, and personally, Alex Guimaras and Guy Maresh for getting the chest x-rays and other x-rays. Without them, my presentation today would. A couple of disclaimers. During my research, I've been using Advanced Computing Center at OHSU, which is on NIH grant. And also daily weather data was provided by a private entity. That I'm going to talk about trauma and shock. So trauma is the leading cause of death for the individuals between ages of 1 and 44 in the United States. And it's also still well, hemorrhagic shock was discovered shortly after World War I. And a couple of researchers, what I found is Robertson and Bach, they were looking at the correlation between blood loss and systolic blood pressure. So they found out loss of 30% of blood linked to significant decrease in systolic blood pressure. Loss of 40% of total volume of blood is correlated with worsening of the decline. And the term hemorrhagic shock was born at that point. So hemorrhagic shock accounts for over 80% of deaths in the operating room, and roughly about 50% of deaths is in the first 24 hours after the injury. Why is that important? So this is the case which was published in a local newspaper in Colorado. So this is not an OHSU patient, and I had nothing to do with him, but it's a public story, and it kind of illustrates the cases we have seen here in the OHSU. And this is an officer who was answering a routine call, and he was shot in the face. He sustained a severe traumatic brain injury, multiple facial fractures, and because head has so many blood vessels in it, he sustained a profuse hemorrhage. So he came in a severe hemorrhagic shock. He required more than 20 units of blood transfusion. This is not the highest I have ever seen or heard about. In my research, there are 40 and more units being transfused for one patient in the operating room, in the trauma bay. What this story signifies is, first of all, we have to be able to recognize shock quickly, and we have to be able to have enough of blood on hand
in the facility to save people like Officer Aaron Pearson. There are a few ways we are currently able to recognize people who need the blood transfusion. And when I looked at the data at the articles, there are more than 24 different ways. Some of them have difficult calculations in it, so they are not practical to use in the trauma way. Some of them are crude, but give the results. So these two methods, shock index and ABC, assessment of blood consumption, they are estimators, they are very crude, they have kind of low sensitivity but good specificity for one, and reverse higher sensitivity but lower specificity for the assessment of blood consumption. So shock index is very simple. You take pulse rate, you divide it by systolic blood pressure, and you get a number. If this number is between 0.5 and 0.7, it's normal. If it's 0.9 or above, patient is in shock. That's associated with higher mortality and need for the blood transfusion. And assessment of blood consumption takes into consideration, it's a scoring system. So it takes into consideration 4 variables. Mechanism of injury, whether it's blunt or penetrating. For the penetrating, we give +1. Systolic blood pressure, whether or not it's below 90. If it's below 90, we give it +1. Heart rate, if it's above 120, then we give +1. And results of the focused abdominal ultrasound. If it's positive, then that means there is blood or fluid in the stomach. That's +1. So 2 or more is indicative for the blood transfusion. And as that, we are moving into the specific aims for my research. So very much like this picture suggests, we are going to lay the foundation and use my aims, like goals, putting them together until we get some results. So my first goal was, first aim was to understand how the decision-making process is happening in the trauma bay. Second was to build machine learning models to predict, to identify people who need the blood transfusion. And third goal was to look at this thing from the system perspective, to being able to identify how much blood is actually needed for the hospital for a given day. And aim number 4 was to evaluate the models. And it's kind of integrated throughout my presentation because you can't really talk about the model without talking about its performance. Diving into the specific aim number 1. So I was looking into exploring the medical decision-making related to the blood transfusion in trauma. So first, I wanted to see how the decision is made, how we identify the patients. Second, I wanted to see what information specifically goes into the decision. And information sometimes means variable we can measure, sometimes not. And last point in that goal was to evaluate, make the statistical evaluation of the variables going in. So I used qualitative mixed methodology for this, and I had online questionnaire. 13 trauma attendings replied to that, and I'm very grateful for this. And then I also dived in semi-structured interviews. Also 11 trauma attendings participated in that. There was a significant overlap, 8 people. And the interviews, I was using iterative coding. That means I was coding as people were talking to me. Then I went back, did the transcript of the interview. I recorded all the interviews. And I was doing iterative coding until I felt I got all the themes which contained in these and subsequent interviews. And they are well-grounded in the data. Last 3 interviews did not bring any new themes, and that was the point of saturation. Saturation means no new themes are coming in, and that's I felt it's safe to stop interview process at that point. The reason I used questionnaire and semi-structured interviews is for triangulation of the data. I looked at the consistency of themes coming from the interviews. This is the data I got through the other means of research like questionnaire. Then at the end, I also did member checking, and we will talk about it in a few seconds. So to put the frame in it, and in my actual dissertation, I used lots of articles from the peer-reviewed journals, and they call this as thin slicing or Eigenblick, which is German for blink of an eye. So there are two systems we are using, and I'm referring to this book by Daniel Kahneman, Thinking Fast and Slow, because many people have read it, and it's actually good read, and it explains the concept. So there are two systems people employ when making the decision. Fast, which is intuitive. It happens in a blink of an eye. We instantly recognize something, and we make decision based on that. And there is a slow. It's more deliberate. It takes effort. We are looking at variables. We are comparing them. We are making some decision, but it makes us think a little bit harder. So system, and in the trauma bay, the decision often starts as a system 1 decision making, and then ideally it moves into the system 2. But a system 1 is a shortcut. It's prone to biases and it's prone to errors. So, and one of the questions I had in my interviews is, did you ever have a patient who you did not expect to need a blood transfusion, but upon arrival, you immediately knew, yes, this patient needs a blood transfusion? And one of the most common answers was, yes, it's more likely in a blunt trauma situation because I'm more tuned to think about penetrating injury as the one which will need blood transfusion more often. All 13 or 100% of my subjects said they did have such a patient. Then I went through the themes and my data, and I was trying to identify the variables to determine if the patient needs the blood transfusion. So one of the themes came up was mechanism of injury. And trauma surgeons have a tendency to divide it into high energy and low energy, and they describe it as an energy going into the patient body, and that energy causes the injury to the body. So every mechanism of injury has a specific pattern and a specific injury pattern associated with that. So then clinical presentation. In the clinical presentation, people said something like, obviously, if patient comes in pale, diaphoretic, most likely they are in shock, they need blood transfusion, and they need to go to the operating room. Some people described if the patient is joking with paramedics and have their legs crossed, they are going to be fine. They don't need the blood transfusion. So age, upon direct question, most surgeons said they don't consider age as an important variable. But when I digged into that, many people said, yes, it actually brings up comorbidities. The older people are, the more comorbidities, and the blood pressure of 100, much more concerning in somebody who is older, like over 70, than somebody who is close to 18 years of age. Visible blood. Many surgeons said it's a visceral indicator. They register it on the subconscious level, and it's blood on patient's body, clothing, and in the back of the ambulance, if they can see it from the trauma bay. Level of the concern of pre-hospital personnel. So that was, if the paramedics are concerned, that tells me a lot. That was like the most common theme about it. Vital signs, then we are getting into the system 2 thinking. So we are thinking now about vital signs, blood pressure, heart rate, respiration rate, and the clinical trajectory was defined as one of the most important, if not the most important, indicator for blood transfusion. So if the patient is stable, they don't need the blood transfusion. If they are declining, they do. Looking at the ways to improve the decision-making which happens in the trauma bay, we were thinking about System 1 associated with the visual perception. That's why you are hearing how the patient looks, clinical presentation, pale, diaphoretic, blood, present visible blood, and other indicators. So to take advantage of the system which is already activated during this process, we suggested to use data visualization, use of photography to contextualize the trauma, not only the injury, but what happened around the trauma, like motorcycle crash or car damage, especially to the front of the vehicle. Use the qualify the EMS concern using something like Likert scale. Use checklists to keep all the important variables, and use of machine learning tools because they have greater sensitivity and specificity. When we did the member check, then I presented them these two simulated patients. So they're not real patients, but the trends, what we usually see, and most of the trauma surgeons said, this is helpful. I did not have that orange line before, and I'll tell you about it in a second. So what you see are in blue, systolic and diastolic blood pressure. Red shows the heart rate. Green line shows respiration rate, and purple line shows Glasgow Coma Scale. So Glasgow Coma Scale is a specific neurological indicator showing how conscious the patient is. If everything is about stable, that's the patient A. So you don't see any decline. When things look like patient B, blood pressure going down, heart rate going up, respiration rate going up, neurological status measured by the Glasgow Coma Scale going down, that's a decline. The orange line, we added this Dr. Kirai just a week ago. When we thought about it, it's shock index times 100 to make it fit on the same table and on the same graph. So we think that might be telling you even more information, providing shock index together this data. Then I got my data. Thank you again. Yeah, so that had multiple demographic variables. And I'm going to show you this data in this couple of slides. So there are strong predictors of blood transfusion and there are weak predictors. Strong predictors are statistically significant correlations, and they are shock index, lactate, base deficit, systolic blood pressure, diastolic blood pressure, pulse pressure, which is difference between systolic and diastolic blood pressure. It shows tissue perfusion, and Glasgow Coma Scale. So all of these variables were correlating the number of units transfused actually. Some mechanisms of injuries are indicative, and that's exactly what came up in the research. So gunshot wounds, motorcycle injuries, they require blood transfusion. Some others, like I'm going to talk in a second, they don't. And age was an important covariate. And weak predictors of the massive transfusion were those which did not have a strong correlation. So by gender, we cannot really decide anything. And there were some statistically significant but immaterial, as my wife would say, indicators like hemoglobin 13 versus 11 and hematocrit 40 versus 34. The magic numbers when we are working on the floor and we see patients hemoglobin 7 and hematocrit 21, that's the indicative for the blood transfusion. Typically, this information comes late after the admission, and body have to equalize the fluids to show the need for the blood transfusion. So when the person is coming in, hemoglobin and hematocrit lag behind. Although the machine thinks it's still important. And some mechanisms of injuries like motor vehicle collision, they can go either way. They might need, might not need, and did not come up as a strong predictor. Vital signs. What I want to say about vital signs, we just talked about them. Most of them are strong predictors. However, one of them is hardly ever documented, and you can see it's the respiration rate. It was missing in 30,000 of my patients. There was a reason that's the main reason I did not include it in my models. And this dead data, I got the data from trauma registry, HR records, and x-rays. And I decided to build some models. And when I asked AI, what do I look like when I build the models, that produced this picture. I think that how tidy my desk and how well my beard is groomed is indicative. The challenges, I got the data set and it was imbalanced. Now, the reason I care about whether the data set is balanced or imbalanced is because the machine learning tools, we created them in our own image. They are not stupid, they're a little bit lazy. So my interest was to predict massive transfusion protocol, and as you can see, it's 1.32% of all patient population. If machine would tell me nobody needs the blood transfusion, nobody needs the massive transfusion, it will be 98.7% accurate. That's an A or A plus in most of the classes I have taken before. There are two other ways we identify people as a massive transfusion protocol. So CAT, it's critical administration of transfusion. That means 3 units or more in first or any subsequent hours in 1 hour. There is a CAT6, which is like sometimes called early MTP. And that's 6 units or more within first 4 hours after admission. But overall, 90% of my patients did not need any kind of blood products, and only 10% required the blood transfusion of any means. So to bring it together, to make the data set balanced, there are 2 ways. You can undersample the majority class, which is in our case, those who did not get the transfusion. And that will bring my total sample to 870 people, which is not enough to train any machine learning models. It's a data intensive process, so we cannot do that. Or oversample the minority class. The minority class, those who had the transfusion, and oversampling, there are 2 ways. One is wrong and one is right. So the wrong way to do it is repeat the same cases over and over again until you match the split by 1-to-1. The reason it's wrong is because the machine will basically memorize the cases and it will not be able to generalize the knowledge. So it can recognize those people who needed transfusion in the past, but no new transfusions will be identified. So to overcome that, there is a technique called SMOT, Synthetic Minority Oversampling Technique. So as you can see, the green dots represent the majority class, right here, and red dots represent the minority class. What the system does, it places these blue dots here, and they are the new synthetic patients which fall within the decision domain for the minority class. So this way we get more normal, like 1-to-1 data split into classes. And the machine is able not only to learn new information, but it will be better, at least in theory, it will be able to better generalize the knowledge. Having that in mind, I built 4 different models to identify people in the need of the massive transfusion protocol. The model I was interested in was MLP, which is multi-layer perceptron. That's the scientific name. It is also called deep neural network, so it has a neural network which has multiple hidden layers. The reason I was interested in it because I wanted to use it in the future model building. For my fusion model, it will come up. But in this particular test, I wanted to make sure this is not inferior to other models. So I had logistic regression shown in blue, random forest in orange, XGBoost shown in green, and MLP, which is a model of my interest, in red. They all performed about the same on this eliciting operating curve. And then I looked at the features which they rank as important for identifying the people who need the blood transfusion. And I found something unusual. I don't want to steal all the fame from Mr. Fleming, from Dr. Fleming, who invented penicillin, but there are two ways to feed the data into the system. You can specify which fields you want to use, or you can specify which fields you don't want to use. I specified the fields I didn't want to use because it's faster. You're not stupid, you're a little bit lazy. But I kept a tally of people who had chest X-rays and people who had pelvic X-rays, and I completely forgot about it. And then it came up as one of the top 3 indicators in 2 models, and the 6th or 7th indicator in the model of interest. When I thought about it, it actually makes sense, because when people in the trauma bay make decision to order chest X-ray or pelvic X-ray, it's not a random decision. They have to suspect it based on the mechanism of injury and based on the possible needs. So that might be indicative on the severity of trauma, or it also shows up as a significant for blood transfusion. I looked at, I tried multiple models and architectures for the multi-layer perceptron. I settled on this one. I had 14 variables for the input, and I had 2 hidden layers. Each hidden layer had 128 neurons, and I had 2 output neurons for the classification. I think I have done enough on that topic, and I moved on my next topic using the chest X-rays. So there are special convolutional neural network which are designed to being able to recognize images. So what it does, it scans the image for some features. That's the convolution, then it pulls them together, then it does convolution again, then it pulls them again, and then at the end, it puts flattened layer, that's where all the features are. It will come up a little bit later in my presentation. So all the features, and then it does the classification. So it can recognize, in this case, Donald, Goofy, or Tweety. Convolutional neural networks have been used before in image recognition, but I have gotten the same problem again, imbalanced data set. Now, there are 2 ways to do it. You can make synthetic X-rays, but that requires, it's much more complex than I thought in the beginning. So to bring the data back to the balance, to balance out the classes, there is data X-ray augmentation technique. And what you can do is on the, here you are seeing the original X-ray. You can do rotation. You can do the flipping. This is why the heart is now on the right side. This is a horizontal flip. You can do change the brightness of the image. Gaussian blur that makes it a little bit blurry, and you can resize the image. So all 5 techniques applied randomly to the images, and that brings the data back to the 1-to-1 ratio. Now, there are multiple flavors of the convolutional neural network. I tried several of them, and I found DenseNet architecture was the best to be used in my case. And it's pre-trained, so it's well known in the radiology, and it has been used to classify pneumonia, to detect pneumonia which was caused by the COVID-19 virus versus bacterial pneumonia. So it's very robust, and it's robust specifically at processing the chest X-rays and extracting the features from the chest X-rays. With that, we are moving at some X-rays. So I wanted to see what the machine is actually seeing on the chest X-rays. So on the right side, right here, you are seeing the chest X-ray. And on this side, this is called gradient weighted classification method. So this is a heat map. What you are seeing here is a 45-year-old gentleman who was assaulted by the metal bar to the head. So there was no chest injury, there was no blood transfusion. This is a true negative case. The only reason I'm bringing it up here is because I wanted you to see this blue screen means there was no activation. On the next screen, however, we are seeing this patient. It's a 50-year-old gentleman who was pinned by a crane. And you can see the area of activation right here. He came in from the construction site. He required 2 units of whole blood transfusion in the trauma bay. And then he was urgently moved to the operating room for the XLAP procedure, exploratory laparotomy. So they opened the stomach. They removed part of the bowel, sutured it back together. And that's how he survived. But as you can see on the chest X-ray, I cannot see any injury, but the machine picked up something. This is an 84-year-old gentleman who was transferred to us as a trauma activation. He was stomped on the chest by a cow. So that's a horrible injury. He came in with a blood pressure of 50/30. He required massive transfusion to be initiated in the trauma bay. He had multiple bilateral hip fractures, sternum fracture, and blunt cardiac injury, and also retrosternal hematoma. So the injury were intense and extensive. And as you can see, everything is activated, but most of the injury, the machine recognizes it's on the lower third of the sternum and on the right side of the chest. So that's a true positive case. And as I told you before, the machine is not stupid, it's a little bit lazy. So it will learn the features which are not clinical, and it will look for them. So this is the case when machine have learned certain letters on the chest X-ray, means this is an urgent patient, most likely he or she will need a blood transfusion, and it concentrated on those letters. So that's the activation. And this is a false positive case. This is machine is also very sensitive to artifacts. So this is a gentleman who came in, and I don't know why did he have a chest X-ray in the first place, because he came in for a sprained ankle. So the machine looked at the chest X-ray and thought, well, I'm seeing something on the right upper quadrant of his abdomen, and I think he needs a blood transfusion. I looked at the CT scan, and it showed he had a skin defect on the right upper quadrant, and he needed a dressing. There's something inside the dressing, so it's, I don't know what it is, but it's definitely an artifact. So taking this into the consideration, so we cannot really use reliably just the chest X-ray to predict people who need the blood transfusion and who don't. But I decided to use the fusion model. So we got the multi-layer perceptron, which gets the vital signs and the data which is available in the first 5 minutes in the trauma bay. And we got the X-rays. There are 3 ways to do the fusion models. So this one, it takes 2 different types of data. So this is an early fusion. It takes 2 different types of data, puts it through the model, activates, and gives you an answer. The problem is that the data should be, it can be different, but it should be similar in structure. So you can use vital signs and you can use blood test results. That will be similar, but different. And you can put it through the same multi-layer perceptron, for example, or you can use chest X-rays and pelvic X-rays. However, if you are using chest X-rays and you are using vital signs, it wouldn't work. Now, this one is a late fusion. I'm going through the models I didn't use, and I'm trying to explain them why. So the late fusion uses vital signs going through the correct model, chest X-rays going through the other model. You get the results after the activation, and then you use this formula assigning to one of the models whatever is you think gives you better results. And once they get combined together, you get the result. What I wanted to do is I wanted to do joint fusion. So two models, convolutional neural network and multi-layer perceptron, they strip the data, they work this the data, and they produce features. And those features are being fused in the last layer of called fusion layer. So, and that's where the activation happens, and that's where you get the answers. The advantage of this method is you don't have to assign any weight to a particular model, but the cost function, which measures the error, being propagated to the original models, and that's where the weights are being changed, and that what makes this model the most accurate, in my opinion. With that, now we need to figure out how we are going to evaluate the model's performance. So this is the fusion model, which uses augmented data. And as you can see, I used Uden's J statistic, which is very simple by the formula. It's sensitivity plus specificity minus 1. And it has a function based on the threshold, which is being provided by the model. And it has an optimal point, and this is where we see the best sensitivity and specificity. This is how it's going to look on the preceding operating curve. So we are finding this point, and the J number is a vertical distance to this line, which we call a random classifier. So this is basically like tossing a coin. You get one answer or the other. If your model performs better than the random classifier, you're good. If your model performs equal or worse, you're not good. And I'm going to benchmark my model's performance to this study. So there was a big trauma study using how to use the blood components. So blood is now coming in components. There are red blood cells, plasma, and platelets. So this study was based on 12 level 1 trauma centers. It was intense, but the spin-off of this study did actually ABC score the measurement of the performance, sensitivity, and specificity for the ABC score. Now, what's important about this study, they used 680 patients, and all of their patients received at least 1 unit of blood. Now, there were patients who were no massive transfusion protocol, 57%, and those who had massive transfusion protocol, 43%. This class balance is much different than mine. So this will come up on the next slide. And this is my fusion model. I would say the performance compared to the ABC score from the previous slide. So sensitivity was similar. Specificity was much better. Now, positive predictive number was much lower, but negative predictive number was much higher. Those, we believe, are related to the class imbalances between my study and the proper study. So, but sensitivity and specificity, I would say those are pretty good. Now, we are going to switch gears and we are going to look at this problem from the system perspective. So we are going to use time series. That's the number of time series is a data measured at the same intervals. So every day we are going to measure admissions and we are going to measure units of blood transfused. And we will see if we can build the machine learning tools to predict that. The problem with trauma patient population is trauma is a seasonal condition. And on this graph, blue shows admissions, red shows transfusions. Transfusions in units transfused, not in number of transfusions itself. As you can see, trauma picks up in May, peaks in July, goes down in November, and it stays kind of stationary throughout the winter time. Similar but little bit dampened similar but little bit dampened pattern you can see in the transfusions. And one of the things I was looking for, I was trying to figure out how we are going to measure the seasonality on a daily basis. And there was an article coming from Norway where they found a way to measure it due to the length of the solar light in a day. So almost perfect correlation. And while looking at the admissions, predicting admissions, we can see longer daylight is correlated with higher admission numbers, warmer weather, higher visibility, so if it's sunnier, and days off, weekends and holidays, we have more admissions. Things which decrease admissions are when it's rainy, when it's snowy, when it's icy. So if on July 3rd, I'm looking at the weather forecast and you see me dancing, because tomorrow is blizzard. So I did the statistical analysis. So we had most of the data came up highly significant except for average sea level pressure and lunar phases. Despite the common belief, I know it's a superstition, nothing we can do about it. Science is hopeless, but it didn't come up as significant. Now, looking at the time series, there are a couple of measurements, a couple of characteristics are very important. So variance, it's how much signal fluctuations we are having. Stationarity, if the data is stationary, it means it's staying consistent throughout the time. And there is a special test you can do, Dickley-Fuller test. So it basically came up laughing at me. So this data was not stationary, the variance was huge. And we needed Box-Cox transformation. So Box-Cox transformation, you have a formula right here. What it does, it decreases the variance and it makes the data more normal. So you can do actually the predictions now. I was able to do predictions for trauma admissions using two different models, XGBoost and MLP. And we came up with mean average error of about 2.5. and root mean square error of about 3.5. So the predictive power is not quite strong, but the data was, I think we got some significant, some good measurement of the prediction here. We are covering most of the peaks when the admissions are going up, and however, when I try to predict actual blood transfusions, I happen to have a problem. And this, when I explained it to my daughter, she suggested to use this cover of the Pink Floyd's Dark Side of the Moon. So when you look at the trauma patients, imagine then they are as a white beam going into this prism, and then it splits into many other colors. So these many other colors represent trauma patients based on the mechanism of injury. So they all different in seasonality because you can see motorcycle injuries, they are starting to peak in May, they high in July, they go down in October. Gunshot wounds, they don't follow annual seasonality, they follow weekly seasonality. So there are higher numbers on the weekends, lower numbers throughout the weekdays. So people just should stay busy. There is also different in the amount of the blood transfusion because ground level falls hardly ever need a blood transfusion. Gunshot wounds are the highest consumption of the blood because they require on average 4 or more units per person on admission. And they also are differ in mortality. So then I looked at the correlation. There is a correlation between admissions and transfusions, as you have seen it on one of the graphs, but when you look, and you can put a fitted line through it, but when you do it, you can also do the scatter plot, and that shows how many outliers are there. So actual prediction of blood on the any given day is not a trivial task. I have used everything in the book, everything I could think of, and nothing really gave me good results. Then I decided to kind of switch around things and look at the blood transfusion predictions if we can predict specific injury, because they are tied in. So I looked at the motorcycle on a weekly basis, because on a daily basis it's difficult to predict. Not every day we get a motorcycle injury, but on a weekly level we can. So those are the motorcycle predictions, and they are kind of decent. They show us the pattern. They don't cover all the highs and lows, but the pattern is quite there. But when I try to predict the actual blood transfusions for the motorcycle injury on the monthly, on the weekly level, that didn't quite work. So, as you can see by this predictive R-square, it's actually negative. So for the trauma blood transfusion needs, I would suggest going with the averages volumes for the days, considering season and holiday or weekends. In conclusion, what I want to say is early augmentation of the system one thinking, this analytical data may help to reduce biases and errors, making decisions better in the trauma bay. Technologically, predicting massive transfusion is feasible, and the data is, after some cleaning and scrubbing, we can use that. Use of convolutional neural networks, this chest X-ray data improves the performance of the multi-layer perceptron using only vital signs data. And predicting future demand in trauma is very challenging due to the heterogeneity of the patient population. This is the picture I asked AI to imagine Mona Lisa as a surgeon. And I think it captures the limitations of my research. So this is a single center, so practices may not be universally shared. This is a convenience sampling. So it doesn't represent the whole spectrum of the decision-making themes done by the trauma surgeons. And this is a real patient database, which means I've been using, there are some errors and omissions in the database. In future directions, I would say I wanted to work on enhancing the model explainability and hopefully looking at the heat maps produced by the convolutional neural networks. Develop blood demand forecast. I was looking at more predictable environment where we don't have like either so many gunshot wounds or the motorcycle injuries are not so severe. And I wanted also to investigate factors influencing clinicians to adapt machine learning tools for the use. And I also wanted to say a huge thank you to my family for supporting me throughout the 7 years. Couldn't do it without you guys. And with that, I'm done, and I would like to open the floor for questions. Ask.
So applying this in the trauma bay, let's say, I mean, can you envision having a dedicated person in the trauma bay who's like hooked up to a computer and putting in all the variables that they're seeing at that moment and giving them, real time kind of output, seeing how that patient is doing and looking for trends? Is it going better or is it going worse?
I think I got your question. So the question was whether or not we need a dedicated person to do it, to put all the data into the computer and see if it comes up as a better decision support ideas. We actually have several people in the trauma bay right now who are doing this job. We have one person who is a trauma intern. They are putting the results of the physical examination into the note as it happens. And we also have nursing person, one of the registered nurses who is putting also the information into the computer as it happens. And in my, if you're going to adapt my study, then basically we need vital signs which are automatically go into the machine, and chest X-ray which are basically automatically scanned.
You think that's feasible?
I think it's feasible. Yeah, this is feasible. A little bit waiting for the results of the blood test. That will be more cumbersome because we have to have the idea. We have to have the decision by then. But this is feasible. Thank you.
So my question is, this is important work for trauma for sure. But there's other needs for blood products also, for platelets, for fresh frozen plasma. Do you think that the tools and techniques that you've developed here are applicable to other fields for conservation of blood products?
So the question was whether or not these tools might be applicable for other fields. Thank you, Dr. Mohan. Yes, I would think one of the articles I was looking at was determining how much of platelets a hospital need for a given day, and they also use two different machine learning techniques. I think we can adopt this idea to identify patients not only in trauma, but in we can use the predictions for cancer care, oncology. Yeah, that could work. Thank you. Anybody else?
And I know Nicole was checking to see if there's anything on chat.
Okay.
I'm not seeing anything in chat.
I think we've given them the obligatory 7 seconds. So I want to thank you, Mike. So I want to thank Mike again. Want to thank all of you for coming and attending and supporting Mike. I'm going to ask for the committee to stay back, please, for the rest of the meeting. But otherwise, thank you, and let's congratulate Mike on his presentation.